The Bioceuticals Integrative Medicine Awards showcase the outstanding talent we have in the Australian complementary medicine profession. Nominations are now open for the 2018 BEMA Awards. For more information and to book your ticket to the gala dinner, visit bioceuticals.com.au/BIMA. This is FX Medicine. I'm Andrew Whitfield Cook. Joining me on the line today, all the way from Christchurch, New Zealand, is Julia Rucklidge. Julia is a Professor of Clinical Psychology in the Department of Psychology at the University of Canterbury, Christchurch in New Zealand. Originally from Toronto, Canada, she did her undergraduate training in neurobiology at McGill University in Montreal. She then completed a Master's and PhD at the University of Calgary. Boy, you've moved around a bit, in clinical psychology, followed by a 2-year postdoctoral fellowship at the Hospital for Sick Children in Toronto. In 2000, she joined the Department of Psychology, where she teaches child psychology in the Child Psychology program and introduced the topic of mental health and nutrition into the wider psychology program. Her interests in nutrition and mental illness grew out of her own research, showing poor outcomes for children with significant psychiatric illness despite receiving conventional treatments for their conditions. And we'll be delving into this with Julia Rucklidge today on FX Medicine. Welcome, Julia. How are you?
I'm great. Thanks for having me on your show.
Now, I've got to say you were actually a danger to me while I was driving because I could not put down your TEDx talk and I kept on having to pull over off into side streets hoping for a red light and everything like that. I dare say there was a time or two when I glanced down, so I apologise to any drivers around me at the time. I found it riveting.
Well, I certainly don't recommend that you watch a video while you're driving. I've never heard this before, but
it was glances.
But anyway, maybe your life is too busy that's the only opportunity you get.
I was in my Zen moment. But take us through your background. What sparked your interest to look at nutrition?
Yep. Sure. Well, I'm a clinical psychologist, as you mentioned, in my bio. And, I always tell everyone that I was told that nutrition was irrelevant in mental illness when I went through graduate school. And that it really played an insignificant role in the development of mental illness and in the treatment of mental illness, and that only drugs or psychotherapy could treat these serious conditions. Mm-hmm. But as you also said in my bio, I was very aware of research that was showing poor long-term outcomes for people with mental illness despite receiving the best care. And if we look at the data, over the last decade, it's certainly true that across the board, whether people are taking stimulants or whether people are taking antidepressants or they're taking antipsychotics, in the long term, we are simply not resolving these problems for enough people. And so I think it's really important that as scientists, we explore new avenues, no matter how controversial they might be and no matter how much they might contravene the current way of thinking. So towards the end of doing my PhD at the University of Calgary, my supervisor, Professor Bonnie Kaplan, was approached by some families who were treating themselves with nutrients, and they were reporting getting well and staying well on these nutrients. And they had, these members of these families had bipolar disorder and depression. Some even had psychosis, and yet these nutrients seemed to be helping them. And so my supervisor was certainly skeptical at the time, and at first told them to go away, take their snake oil somewhere else. But she then was convinced by some data that they shared with her and showed her, people getting well. And so she decided to study the nutrients in the earlier part of the century. And so she and others actually published some very preliminary data in 2001, 2002, that certainly convinced me that it was worthwhile looking at it. And, taking that in the context of what I've just described, that in the long term, we're not doing very well in terms of addressing mental health issues. The number of people with psychiatric illness is going up. It's not going down despite receiving the best conventional care. that I decided to study the nutrients. And so that's what I decided to do back in, over a decade ago, 2005, 2006.
Yeah.
And I haven't stopped.
Okay, so some of this smacks of my stance, I guess, when I was a registered nurse. I was totally blind, totally ignorant, totally arrogant, would not accept. You could have put any study in front of me and I wouldn't have accepted it. I merely would have said what I had been taught ad verbatim, vitamins and herbs are of no use.
Yeah.
So how did you open up? What was it that tweaked you to think, maybe?
Yeah. As it is for many people, it's seen a case get better. And so my first case study that I published was on a young man with OCD, and so obsessive compulsive disorder. And he had actually been seeing me as a psychologist for over a year. And I had, given him the best cognitive behavioral therapy as, the best treatments that are recommended for the treatment of OCD. And he had really marginally improved over that time. We had a very good relationship. He didn't mind coming to see me. But if we looked at his symptoms, they had really only had a modest change over that period of time. And so then I was in the situation where I was thinking about using the nutrients. I was skeptical. I was not sure where I was going to go with that. And I had some free nutrients that had been given to me. A trial that we'd wanted to get going we were struggling with it. There were some problems in getting it going and off the ground. Many reasons for that that I don't need to go into. But I had these nutrients, and so I said to the family, "Look, I have no idea if these are going to work for you. There's a case study out there of a boy who had OCD symptoms, seemed to have helped him. Yep. I have no idea if this is going to help you. But we've offered you the, psychotherapy. The family at the time were unwilling to try medications. And so I said, what do you have to lose?
Yeah.
And so this young man took the nutrients, and he came in 2 weeks later, and he and his mother said, the OCD is gone. And you don't have that experience very often in my world, that kind of thing happening to you. And so I paid attention because I'd heard about this from my supervisor. I have great respect for Bonnie Kaplan. She had told me about families getting well. I trusted her. It's still hard to believe even when someone tells you it. But when you see it, you see someone get well with nutrients, someone who you've worked with, it's not a placebo effect because you've worked with them for so long. Yeah. There's no way it had anything to do with, it could, I suppose you could still claim it was a placebo effect, but it just was so dramatic. And we'd worked so hard to try to change this young man's OCD with really such little success that I was impressed. And so we monitored him over time. After 8 weeks, he was doing really well. The family decided to stop the nutrients. This OCD symptoms returned.
There's your challenge.
And then we put him back on them, and then the OCD symptoms got better. He went off. So we did what's called a classic A-B design with this young person, and really saw that there was on-off control of the symptoms with or without the nutrients. So that was enough to get me really curious about what was going on. And then up until then, I was always like, vitamins and minerals, why, as you say, why would they work? That doesn't make any sense. But as soon as you delve into it, you realize it couldn't make more sense that every single biochemical process that happens in our bodies require cofactors. Cofactors are vitamins and minerals, and they're required for all of these chemical reactions to be occurring. So for us to be so arrogant, as you use that word, to suggest that it's meaningless really is not doing it's really doing a disservice to just understanding basic physiology.
Absolutely. So how then do you talk, particularly now, given your understanding of over a decade of use, responsible use of micronutrients, macronutrients in mental health disorders, how do you talk to colleagues who are still skeptical, do you grab them round the throat and shake them round?
No, I've learned that doesn't work. I've learned that when someone's mind is closed, someone's mind is closed,
Yeah.
and it's like with any debate that they've formed an opinion, and that it's very hard to shift them from there. So I've just taken the approach of we use data, and
Yep.
so. Fine, if you're not going to listen to our early work, our open label trials were pretty much dismissed as that they were the reason why we observed people getting better on the nutrients was because, of course, was the strong placebo effect, and that's why these patients were reporting themselves getting better. Again, when we did an open label trial of 14 adults with ADHD, and just hearing these patients come in and just telling me they just hadn't felt so calm or so regulated, just didn't have the ups and downs like they used to have. They just felt really, they felt normal. It's often what people will tell me. And so, after a while, I've gotten used to those stories, but it's certainly in the early days, I was still just stunned that just vitamins and minerals could have such a powerful effect for some people. Certainly not everyone. Not everyone responds, but a good proportion of people do. So we just sit here in my lab, and we run clinical trials. It's not my favorite pastime to do randomized control trials, in that they're challenging, they're difficult, it's hard to get people enrolled. They take a long time, they're expensive, but that's what we have to do. And because that's what people will listen to, is that if you've done a properly designed randomized control trial, fully blinded, using a placebo, then it's hard at that point for people to ignore you, especially if as we've been able to successfully do, is to publish it in good journals.
Yeah.
That's been the other challenge, is to actually publish this work. Sometimes I go into this so naively. I think, okay, we finished our first RCT with the adults with ADHD, was our first blinded RCT. We've done a few RCTs after the earthquake, but those weren't blinded.
Right.
But our first blinded RCT, I was done exactly like a drug trial, where we'd followed the protocol of how you would have done it if you were using a stimulant instead of nutrients, and the statistician was independent of our program and analyzed the data independent of us, and done perfectly in those from those perspective of how you run an RCT. I was surprised at how hard it was to publish it, and that the work was getting rejected by journals without even being reviewed.
Oh, really?
Yeah. Yeah, it was. So it was like, but what we've done, I was told that your sample's too small, but when it comes to sample size, you do a power analysis and you determine what sample you need based on, pilot data. And so we'd adequately powered it. I had some ridiculous things like, this is better for a child journal, which suggested they didn't even read the title, which showed that it was with adults. It was really an interesting journey to find out what types of excuses were used to prevent it from even being published. So, but fortunately, we did get it into the British Journal of Psychiatry, which is a really good journal, well regarded. And it was at that point that people really then started to struggle, that they couldn't ignore it anymore, that there was something to this. And so that's what we've had to do. That a long answer to your question around how do you try to convince people and to get them to change. I think you have to do the hard work, hard labor of doing the types of trials that they will pay attention to.
I'm so glad you covered the point, though, of power analysis. It's not often talked about. And this is something, in fact, perhaps you can give us a definition of what that really means when you're looking at, psychiatric versus cardiovascular versus what sort of intervention you're trying to look at.
Yeah. Okay. So a power calculation is where you decide how many people you need to put through your study in order to detect a significant effect. And so what's really important for your listeners to understand is that if you have a really, really big study with lots and lots of people in it, then it has the opportunity of being able to detect group differences. And oftentimes you'll detect group differences with really, really large studies. But the group difference will actually tend to be quite small. So we've been a little bit, the wool pulled over our eyes in a way from really big RCTs that have been published by the drug companies, because they often will have very large samples and they'll detect a group difference. And so they'll say that for example, the antidepressant was superior to the placebo. But what the lay person and the public won't realize is that the group difference is very small, because with those large studies, you can detect very small effects.
Yeah.
And that's, though, in a way, that's interesting. That's important. It's good to see that the treatment group was better than the placebo group. But then we also have to think about the magnitude of that effect. And so if it's a very, very small group difference, but it's significantly different, at that point, you do have to weigh that small group difference, the benefit that you get by taking the antidepressant versus the potential risk based on the side effects. And so you really need to weigh those carefully. But if you have a small sample and you detect an effect, that means that the group difference is much larger, and so that means that the effect is much larger. So because with a small sample, you can only detect a large effect. Yeah. So with our study, but having what's usually viewed as a fairly small sample, there was 80 adults, 40 and approximately 40 in each group. Then in that kind of situation, if you find a significant group difference, then your effect is going to be at least a medium to large effect. And so then that makes it more clinically relevant. And that's when if you have a large effect and then your side effect profile is really minimal, which it is with vitamins and minerals, at least based on the data that we've collected to date, then you have a bit more confidence that if it's worth trying this treatment, because the chances of it working are much greater and the risks associated with it are much smaller, relative anyway to the medication. So I don't know if that's answered your question about effect sizes.
Absolutely perfect. But flowing on from that, we see, for instance, like, antidepressants, you've really got to flip the coin chance of it working or not working on a first choice of antidepressant. And I guess you hone that over time with regards to what might work or what doesn't for your patient. Just including the micronutrient of zinc might help it to work better, regardless of first choice. I guess where my flow-on question from there is, when you're looking at biochemistry and you're looking at adequate intakes of foods and micronutrients, are we looking at a pharmacological effect here of the nutrient, or are we only looking at correcting a deficiency? Right. I.e., can we force our way through broken machinery, like the concept of methylation?
Yeah, a good question. Hard to answer, not quite sure, but we think it's having a pharmacological effect. And so I think it's more than just correcting a deficiency, because correcting a deficiency would require a much lower dose than what we're using. If you're just looking to prevent yourself from, say, getting scurvy or rickets, then you don't need as high a dose of, say, vitamin C in that situation or vitamin D, than if you're trying to determine what is optimal level for brain functioning. But on top of that, you're talking about, is the system broken? And we do wonder whether people who have mental illness do have something going on. Is it, driven by genetics? Is it because of environmental insults? It's hard to know, but it may very well be that their biochemistry is not working as optimally as other people, and that in turn they therefore need more nutrient than what someone with a normally functioned biochemistry would need. And so we might be, dosing, having to provide more in order for that biochemistry to work, work optimally. So for the biochemical reaction to work, you might need to provide more enzymes and coenzymes than you would if the biochemistry was working properly. And that might be because of SNPs in specific genes.
So here we get into something. So I'm going to tie this in, and it might seem distant, but the work of Professor Lynn Griffiths with regards to migraineurs on Norfolk Island. I asked her if she found an issue with methylation with regards to the SNPs, and she didn't. She didn't see that she had to use the quote-unquote active folate. She just used folic acid. She didn't seem to see this. Have you found this, though? Because it just seems to me to be not just an area of great interest, but what I'm getting from the feedback from clinicians is, you can use one form and it will work not at all or too much, might aggravate symptoms. So it really does seem to be quite personal.
Yeah. So I can't answer your question because we haven't been able to address that appropriately through research. So in our research, we are always giving people the same combination. And you can't really do anything other than that in a double-blinded trial. Because you can't individualize the approach. You can't give some people, what you think would match that biochemistry versus giving somebody a different, nutrients because of their biochemistry. Yes. So I've put a lot of thought into how can we do this and try to address things like the MTHFR and, are there people who would do better with methylated folate or others who would do better without it or just, without any folate? Because I've certainly heard about those issues that have been raised clinically. So as far as I know, at this point, we've got a lot of the clinical data of people saying, I think that some patients do better on this specific nutrient versus not using that specific nutrient as you're describing. But whether, as far as I know, the research isn't there yet to say that there are, if you've got a specific biochemistry, then we need to match it. That just hasn't happened. We are doing our best to start to try to answer this, but it's actually not a simple thing to study. No. To look at whether or not you can correct biochemistry through giving nutrients, because you then have to look at whether or not you're changing genetic expression, and that's not a simple thing to do, nor is it a cheap thing to do. So we are trying to explore this, but whether or not we succeed in determining whether or not you can predict who should, what nutrients you should give given someone's biochemistry, I just don't think we're there yet. I know some people would argue with me, but I would say just show me the data. Yeah. Show me the data that someone does better, on this particular nutrient versus another one, particularly when it comes to either methylated or unmethylated. I've heard a lot about it. Yeah. It's very contentious, and it just seems that, as you say, we're just not there yet. There are those people that make that specialize in it. But the data isn't there to back that sort of choice of therapy up. Yeah, you'd essentially have to, you could do it quite easily. I mean, well, not that easily, but you could test somebody for MTHFR, for example, and you could then randomize people, even if they've all got this genetic mutation, you then randomize them to either, one or another, and see what impact that has on their symptoms. I suppose you could do it that way. As far as I know, it hasn't been done. I'm just trying to think. That's a single nutrient. There might be some stuff on that, but I'm far more familiar with the combination approach of what we've been doing, which is to give a whole bunch of nutrients at the same time and see what happens. I mean, I've certainly reviewed the literature generally on using single nutrients, and overall it's modest. Some people will benefit from that, others won't, and the overall effects are pretty small. With some exceptions, there's a few exceptions where you get larger effects. But the approach that we're taking is more of a shotgun approach. Give everyone the nutrients that are needed to make sure that the mitochondria are well fed, that that you are addressing all of the nutrients that are required for the methylation cycle, that you're ensuring that the gut or the gut bacteria are well fed with nutrients, and then see what happens, rather than taking the approach of let's just try to fix this little bit of biochemistry that's wrong, because I just don't think we're at the point where we know what's wrong. And so to take that approach of let's just give that one nutrient, it's actually not appreciating that they work synergistically together. All the nutrients are working together. You look at the biochemical processes to make neurotransmitters like serotonin, and you see that it requires a whole host of different nutrients. That's and the same goes with the mitochondria and the Krebs cycle and making ATP, that a whole host of different nutrients are required. So why we would think that we could fix it with just one nutrient actually doesn't totally make physiological sense. No, it's a whole paradigm shift that people, if they want to embrace natural medicine, they really have to get out of pill
drug type mentality. It doesn't work that way. That's why we eat breakfast.
Exactly. That's right. We eat a variety of food because that's what we need.
So let's move on from there. Felice Jacka has done great work with diet and mood disorders. Mm-hmm. Do you then employ, or do you find effect of using micronutrients even given a poor diet, or do you really need that foundation there first, that they have the diet and then micronutrients can work?
Yeah. Great question. Okay, so we don't manipulate diet in any of our studies. So they come in and we have a great variety of diets that are being consumed by our participants. Some do have great diets, and some of them come in with having just eaten at Kentucky Fried Chicken and bring in their Coca-Cola. So we accept anyone, and we don't make any comment about diet. Not that I don't think it's important, but because we can't have them manipulating their diet while we're giving them nutrients. So, so it works. So we've looked at whether or not people change their diet and whether or not that might better explain the changes in symptoms over our RCT, and that doesn't. People typically don't change their diet. There are a few who come in and go, "Oh, this is a study about nutrition. Maybe I should change my diet." And we've certainly had that happen. But it doesn't actually happen that often. That people kind of make that, put two and two together and go, yeah, I should actually change my diet. So, but what Felice's work has shown is that if you come in with a really bad diet, you shift someone towards a healthier diet, like the Mediterranean diet, which is the smallest trial, then you can have a positive impact on mood symptoms. And so, but the question is that are there people out there who, even when that happens and they get switched to a better diet, do some people actually need more nutrients than what they would get out of a good diet? And that's something that we don't really know the answer to yet. So we'd have to do a comparison of the nutrients versus a dietary change, perhaps, in order to know whether or not some people actually need more nutrients. I think some people do. I really, having seen enough people through our clinical trials and hearing about some people who come in with fantastic diets, eating really well, lots of fruits and vegetables, lots of fish, healthy fats, nuts, etc., and they're still struggling with a lot of mental health symptoms, then you know that that's not going to be enough for them. And they may have that type of biochemistry that just needs more nutrients, and that that's in order for their biochemistry to get corrected. So that's what I think, but we haven't studied that empirically. It's a really hard study to do. I mean, if we're going to get into that, randomizing people to nutrients or dietary change, that's a tricky study to run because there's no, you can hear it already. There's no blind. So you'd have to try to solve that. You'd probably have to do a 3 or 4 arm trial, and then you're looking at 200 people. So I haven't gone there yet. So I mean, for me, I see that as important, but I also think that my role at the moment is getting nutrition on the map. With our research, and we're showing that just giving vitamins and minerals can have a positive impact on mental health symptoms. And across the board, we've looked at it with sleep, we've looked at it with ADHD, we've looked at it with stress, PTSD following earthquakes. So we've looked at it with a whole host of different symptoms. And yes, we see that these symptoms get better. And so we are putting on the map that this is relevant. If you then take our research and you say, okay, let's eat better, fantastic. That's great if we have that impact on getting people to really be considerate of what they're putting in their mouths. I'm delighted, even though I haven't done those types of studies. We can't supplement the whole world. No, so we'd much prefer that we invested in good food, ensuring that our soils are properly replenished with all the minerals that are required. At the moment, we don't do that enough. And so our soils are depleted in nutrients. There are challenges with just overall the nutrient quality of our food. That does mean that for some people, they have no choice but to supplement in those circumstances.
I want to ask a question a little bit later about ligands of the micronutrients that you use, but In the meantime, with regards
Don't know if I can answer that question. I'm not sure.
What about things
But anyway.
like compliance issues with regards to
Yeah.
you're not taking one little tablet to
Yeah.
block effectively block a biochemical process. You have to nourish things, and this is the issue that a lot of orthodox medical professionals have with nutrition, is that you're getting a plate full of tablets, sort of thing. How do you find the issue, therefore, of compliance with any sample size, but let's also include kids?
Right. Of getting them to swallow the pills. Is that what you mean?
Yeah.
Yeah. Yeah. So we have some really great data on compliance from our studies. And so we collect pills after a couple of every 2 weeks. So we collect back everything that we've given to them. We have them report back to us on how many doses were missed, so that we have a pretty good idea of whether or not we can get people onto this schedule.
Yeah.
So we work hard to get people in our clinical trials to take the pills 3 times a day, because they need it to take up to 12 pills a day. So that's 3 times a day to be in our to get the full breadth of the nutrients that we're giving. So our experience has been, yes, we can do it. So and these are people with ADHD for the most, the ones that have been our blinded trials.
Mm-hmm.
So they are people who inherently struggle with, remembering things, paying attention, all of those things. So we've been able to get people like that to follow the regime of taking the pills 3 times a day.
Yeah.
And so I guess the answer is you can do it. I mean, I think for some people they might require that, maybe some text reminders or other, useful electronic reminders to help them get on track. But as soon as you get into the routine of taking it with every meal, then we find that we can actually get people to remember. There will be people out there who just can't do it, but I've been actually pleasantly surprised at the number of doses that actually do get consumed. And we can also confirm that because we send them for blood work and we can see that nutrient levels are going up. So we do know that it's not just about them telling us what we want to hear.
That was my next question.
It's actually being confirmed by the nutrient levels in blood. Some nutrients don't change just because of homeostasis, so you'll never see a change in some of them. But there are nutrients that are good markers of compliance, like B12 will go up if you're giving people a large amount of B12.
Yeah, that's a salient point, actually, the elegant machinery to bring the body back to homeostasis. If you don't know what you're measuring nor why you're measuring it, then you can say, no, it's having no effect. This has been raised years ago with, for instance, oral glutathione. Do you employ more than just B vitamins and minerals, though? Do you employ these, nutrients called, N-acetylcysteine for ticks and things like that? Do you find that they're of any import, or do you tend to look at the basic micronutrients, minerals?
Yeah. Well, I have it. I'm a clinical psychologist and not a pharmacist and not a compounder.
Yep.
So I do not put the micronutrients together.
Gotcha.
So remember the story that I told you, which was that there were these Alberta families who were treating themselves with nutrients. They're the ones who developed the formula that we've been studying. It has changed over time because that was over 25 years. Is that about right? It probably was about 25 years ago.
Yeah.
So the formula has changed over time, but that's the one that I decided to study. For the most part, is that there's just no other company that's actually decided to provide or to produce a nutrient formula that targets mental illness. Most people will, many supplement companies will do things that target the well population, but not really mental illness. If you think about it, because there's more money in wellness. There's more people that you can get to consume your product. So why would you, restrict yourself to a smaller percentage of the population, right? It makes kind of,
it does make sense. I wonder though whether part of that might be claims. You can't claim. So.
Oh goodness, yeah. Where do we go with that one? That's just
that's a nightmare.
Kind of words on claims. I could talk about that. So just to finish that story is that the company in Alberta made the product and specifically targeted for mental health symptoms. They've gotten into a lot of trouble with Health Canada about claims. They don't put claims on their labels. That doesn't exist there, but people know that that's what the product is for.
Yeah.
And so, but I mean, the nice thing about this particular formula and working with this company is that there are no strings attached. So I do not receive any money from the company, and they don't pay me to do this research. They give me the micronutrients and matching placebo for free, with absolutely no expectation of what I do with the data that we collect. So that means that they can't influence me on what I publish, how I publish it, where I publish it, what study I run. They just give it to us for free, and they'll give it to any researcher anywhere in the world for free if they're going to research it.
Yeah.
So there's not a lot of companies out there that will give you their nutrients with no strings attached. I've certainly been approached by other companies over the years, and that I just say to them, I'm happy. Like, people will say, I'll get an email, why don't you study my product? Okay, I'll happily study your product, but these are the conditions.
Yeah.
You give it to me for free. You give me a matching placebo, and you don't have any control over the data.
It's got to be that way.
Who's going to agree?
Otherwise,
Who's going to agree to that?
Well, yeah, there's no point. There's no point in doing that data if it's tainted from the outset.
Yeah, so that's why. But that's why we've had to run it it's been so important to not be tainted, in order for us again to be taken seriously. Because if I had accepted any money from this company or any other company that we've studied their products, because it's not just this one company, there are other ones that we studied, then I will get immediately tarred with a big brushstroke of the huge conflict of interest. And so I have been able to keep completely clean of any industry money. There's not a lot of researchers out there who can keep that claim, and that's been 10 years. So all our funding comes from independent sources, either people who are interested in our work, who decide to donate money to our research, or that I've gotten small grants from here, different places that have managed to help me fund these studies. We run it very much on a shoestring budget. There's not a lot of bells and whistles, and I do what I can do with the money that I've got. But we've been able to do an awful lot with a very little amount of money.
Brilliantly done. To maintain your ethics.
Absolutely. Otherwise, I mean, again, the number of people who have accused me of getting money, that's huge. It's even, in the British Journal of Psychiatry, someone wrote a letter saying that they must have ties to the industry. And I had to, even though we declared no conflicts of interest in our paper, had to go back to them and say, well, actually, no, we don't. I mean, this is how it is. This is how we've chosen to run our research, is to have to receive no money from the industry. I think it's so corrupt. I think the pharmaceutical industry has become so corrupt that it's really, really hard to believe that there are some people out there that are actually, will do it this way. We just had to. There was no way we could be taken seriously if we didn't do it this way.
What about looking at micronutrient therapy versus antidepressant therapy, or stimulant therapy in mood disorders, behavior disorders? I've thought about it, and I at this point I haven't done it because for lots of reasons. We really need to, again, as I said before, we've got to put this on the map, and the only way we can put this on the map is just running, head-to-head trials of placebo versus nutrients. If you were to compare it to stimulants, in the short term, stimulants have such a huge impact on ADHD symptoms. Like, in terms of, these kids are suddenly, within a few hours, calmed down, that we would never be able to have that same level of effect in the short term. And it would be very hard to run a very long-term study. So in the short term, I think stimulants would win. And I always tell people that if you want to have a very quick change in your child's behavior, then micronutrients is not the way forward, because the changes are going to occur very gradually over time. And so you're not going to have an immediate hit within the next 3 or 4 hours that you take the micronutrients. So they're apples and oranges. They have such a different effect. The stimulants are very, so effective in that short term that we simply can't compare
And so, and that's not necessarily a bad thing. They just work very differently. And you just, at the end of the day, have to weigh up, the long-term effect and the risks and benefits. And that's where I think micronutrients would come ahead. It's like the hare.
Yeah.
Is that the right? Is it the hare that goes slow? Is that the one?
The tortoise and the hare.
Turtle.
Tortoise and the hare. Yeah.
Yes. The tortoise and the hare. Sorry, it's a tortoise, isn't it?
Yeah. Tortoise goes slower,
okay, sorry.
but he wins.
So your Ritalin is the hare. Would that be right?
That's
and your micronutrients are your tortoise. So I've just come up with that analogy. I hope it works. So So the micronutrients in the long term, like when we observe people over a long period of time, that not only do we see changes in the symptoms that we were targeting, but we also see wonderful changes in other areas as well. So we will hear of improved sleep. We will hear about stabilization of mood. They're a lot better regulated.
Yeah.
Parents will tell us that their kids can be reasoned with now. So it's not, and we don't take the child can still be active, so we don't remove their activity. But, my perspective as a parent, I would say, do you really want to completely sedate your child?
No.
Probably not, but it'd be nice if there was greater control over it. That's what the micronutrients seem to do. So they don't sedate them. They can still be lively kids, but they're less anxious. Or as I said, their mood is more stable. And I guess a parent has to weigh those things in the long term. Do I want to achieve an immediate change in their ADHD symptoms at the risk of having long-term potential challenges? And what we do know in the long term for stimulants is that the child will very likely be shorter than what they should have grown. And that in the long term, kids who are taking Ritalin are no better off than kids who haven't taken Ritalin. So their symptoms are exactly the same when you follow them over the long term. So you kind of say, okay, well, is that worth it? Is that, that they're going to be shorter and their symptoms are going to be no better than someone who never took this drug. Mm-hmm. So that's I think what people have to consider. And in the end, what we've noticed with micronutrients is if you stay on them, then we continue to see good stability of their symptoms and maintained that they're that their symptoms are well controlled over a long period of time, and that seems to stay. That we continue to see that over time. We haven't, in terms of growth, we haven't looked at that in the long term because we just haven't had that opportunity. But we are intending to do that. But we do find that the kids eat, that the parents report that they actually have good appetites when they're taking the micronutrients as opposed to what you'd expect to see with the stimulants. So there's God, that was a long answer to your question of do we want to compare the micronutrients to drugs? And you can see some of the challenges of what would it achieve. Because we would actually just show that with respect to ADHD symptoms, you would probably get a bigger effect with the stimulants.
Yeah.
But that may not necessarily be what you want. What is actually in the best interest of that kid in the long term.
When you're talking about the evolution of this product that you've been using, do you personalise it, quote unquote, to the Australian, New Zealand landscape? I see actually quite a big difference there. But I guess where I'm referring to here is in Australia, every pregnant woman since 2010 is now recommended to take not just their iodine-enriched food, but a supplement as well, because the iodine-enriched food is not enough to support the needs of iodine in the pregnant woman. And and the addition of this supplement has helped IQ levels and things like that in kids. I'm not
just giving iodine.
I'm just giving iodine. Now, is it the same for the soils, the geological makeup of New Zealand?
Mm-hmm. Yeah, so iodine and selenium are very deficient in New Zealand.
Gotcha.
And so those are, of course, two nutrients that we need to make sure that we do get in New Zealand. So we're currently running a pregnancy study, so I'm up to date on all of that.
So that was my next question, because we're talking about preconception to prevent this sort of thing from, or hopefully to prevent these sort of disorders from happening in the first place. But there's a couple of things I need to delve into, and that is, do you find, I know that you're academic looking after these studies and that, your role is really the controller of these studies, but in practice, do you find that the long-term use of the stimulants to control behaviour, or indeed the sedatives to control behaviour in some instances, is actually doping down a gift that some of these kids might have?
I think some people would argue that that's exactly what they do, but and I think that would still be up for debate about whether or not that's actually what happens. But what we do know with the stimulants is that there's no benefit to academic achievement, which is something that people should really stop and think. You've got something that seems to be improving your concentration so that you can do your homework. And parents will tell us that their child is finally able to focus. And so you'd think that should translate into better academic outcomes. But all the studies that have been done looking at long-term academic outcomes, there's no advantage to having taken the Ritalin.
That's only on the Ritalin.
Stop and wonder. Huh?
That's only on the Ritalin, yeah. What about with using micronutrients as well? Is there any difference?
Micronutrients.
With the academic performance?
Academic performance. I think most of the studies are, I haven't looked at this really recently, but my understanding of the studies that have been done using micronutrients for normal children is that there is some intellectual advantage that is conferred by using the nutrients. So that but it depends on the study, because I don't think all studies have necessarily shown the benefit. They haven't shown a decline, but some studies have shown that the kids who take micronutrients are at a greater advantage.
I guess where my mind goes with this is, I wonder if ever, Einstein was known for his social ineptitude,
Yes.
And I wonder if he were born today, would he be over medicated, and would we be seeing the things that we term as genius? So
Brilliant.
I gotta ask this question: are we really dumbing down some geniuses out there?
Oh, I don't know. I hate to comment on that one and say that happened.
Another study.
So, there's certainly some research that's been done on creativity and ADHD. One of my PhD students from many years ago looked at that. So, that there is a debate around whether or not kids have ADHD or whether or not they're creative. And we found that it was overall mixed findings on that one.
Right.
So some kids are creative, some have ADHD and are creative, some are creative, don't have ADHD, and et cetera, et cetera. So, I guess I'm not going to, I don't want to be held to anything on that one. If Einstein was born today, would he have been medicated? Maybe. And would it have produced the brilliance? I don't know.
Yeah.
Yeah.
Now, you've got MedSafe as the regulatory body in New Zealand. We've got the TGA, which, despite its failings, really is the envy of the world with regards to quality testing and things like that, manufacture.
Yeah. Mm-hmm. Mm-hmm.
Would this supplement be approved for TGA, or would it?
No.
Because New Zealand is rather liberal in its inclusions of.
Yeah, I mean, you touched on this a little bit before about health claims, and that's sort of part and parcel of the legislation. So, the problem is it's a very much a gray zone at the moment. We've had the National Health Products Bill has been in front of Parliament, and as at its third reading. Yeah. I've been involved very much in petitioning it and preventing it from going through. And so far, we've been really successful at preventing it from going through. What it would essentially do, what they're claiming it would do is give greater confidence to Kiwis about claims that can be made on supplements, but it would also limit the doses that would be allowed. It would basically take in the TGA limits that are there and apply them in New Zealand, and make it even worse because they would take some of the limits that are applied in Canada and take those and basically take the lower limits. So we would really lose out in terms of opportunity to be able to use things at a therapeutic level.
That's the whole point.
So it's it's such an interest. It's a really interesting area to delve into. Essentially, though, if you have allowing health claims to be made on natural health products, they say is a good thing. But if you actually start to delve into it, and there's a lot of health claims that have been proposed and put forward for New Zealand that, it will support, mood, or will support cognitive functioning. But when you look at the research, and, the really good example here is the VitaCog trial, which is a trial that came out of the UK that showed that if you use three B vitamins at a certain dose, and I can't remember all the doses specifically, but they could assist in preventing cognitive decline. So that health benefit is allowed in New Zealand, according to this new bill. But the doses that are required in order to match that health claim aren't allowed, because they were putting limits on B12, like really low limits on folate, et cetera. So they're saying that we're going to allow these health claims to be made, but they're not allowing the manufacturer to use the nutrients at the level that is required in order to be able to make that health claim. Does that follow?
Oh, yes. Call me a conspiracy theorist, but I do stick to the adage that just because you're paranoid doesn't mean you're not being followed. And
Exactly.
I wonder if this is a backdoor way of allowing Codex Alimentarius to prevail.
You got it. Exactly. And so we all need to be really, really suspicious of that kind of legislation that wants to limit the levels, because they also claim that it's about safety. And I've done a lot of submissions, again, to our government around safety of nutrients, and produced all the documents that are required in order to show that, for example, B12 is a great example. Yeah. B12 is limited at a very small dose. Based on for TGA. I know that TGA, I can't remember what it is for. It's just a few micrograms. B12 is a good example. Is where they put a really low limit on it. And yet B12 is water soluble, and there's no toxicity related to B12 whatsoever. So there really shouldn't be a limit on it. There's no need for a limit on it. So why have they limited it? Why is that being put forward? So you have to then wonder, what is the ulterior motive to put a limit on B12? Because we know that B12 is so important for good mental health functioning, and we need it at those really high levels in order for it to have the impact. So that's one of those really curious ones where they're claiming safety and keeping New Zealanders safe, but actually the data don't support that. So when I started to, started going through all of the 5,500 ingredients that have been put forward with all of their dose restrictions on them, and started to go through all the vitamins and minerals and see these dose restrictions, they were not logical. They were not based in science. And so that was my huge objection to the whole thing, which is that they're saying it's about keeping Kiwi safe, and it's not. And you guys have the TGA, and you've got limits on your nutrients, and it's not about safety. It's about preventing nutrients from being used at a medicinal level. Because that's where, you can get these nutrients at those therapeutic doses, but it has to be registered as a medicine. Yeah, that's right. So, and so do we really want nutrients to be limited, to have the access to nutrients being limited in that way? I would say we should resist that as much as we possibly can, because that's essentially saying, we're going to control and tell you how much nutrients that you're allowed to have. Selenium is a great example. Selenium is being limited, and I'm sure it's Australia and New Zealand as well, at 150 micrograms. So you can get that amount of selenium out of 5 Brazil nuts, as long as they're from Brazil. Yeah. So they're saying, well, it's okay. I could have 10 Brazil nuts. I'm assuming that there's no limit on the number of Brazil nuts that I'm allowed to consume. But if I want to take that in a pill form, I'm going to have to go to the doctor and get a prescription for it. Yeah, that's right. Yeah. Just looking at mental illness, the statistics are showing that the number of people with mental illness is on the rise. We haven't trained enough psychiatrists and psychologists in order to be able to meet the growing demand, nor will we ever be able to. We don't have enough personnel on the ground to be able to meet all the needs of our community with health professionals. And yet that's what we're expecting essentially how to solve this problem is that, just train more, give more drugs, which is exactly what we're doing. 1 in 10 New Zealanders is on an antidepressant. I'm sure it's similar in Australia and other countries. So So that's how we're responding to this problem.
Yeah.
How about we respond and say, okay, how about we look at their nutritional needs, because we know that they're probably deficient, and that it's a pretty cheap option to see if we could just raise everyone's nutrient levels to a higher level. We'd probably eliminate a good chunk, not everyone, but a good chunk of people, and be able to just resolve mental health problems in that group. Then you leave the ones who are much more, serious and who just don't respond to that approach. Then we've got professionals available for that. But wouldn't it be nice if we could just take a little bit more charge of our, educate our public and take more charge of things that they can do in order to improve their health?
Professor Julia Rucklidge, I can't thank you enough for that, particularly that last wrap-up paragraph, because I can hear in the emotion in your voice about, it's almost, you're almost pleading for the government to take heed of the need for this sort of intervention to take place. So I thank you for joining us on Ethics Medicine. I wish you so much good fortune with your research that you're undertaking at the moment. And I'd love to have you on Ethics Medicine at a future time. That'd be great.
Sure. Always happy to talk, because these messages need to get out.
Yes.
And we haven't successfully got the message out yet. So as long as that message hasn't broken through and people are telling me how everyone's on nutrients and we're kind of bored of hearing about it, I need to keep talking.
Well done. This is FX Medicine. I'm Andrew Whitfield Cook. Hi, I'm Andrew Whitfield Cook. Here at FX Medicine, we strive to remain clinically relevant. So stay in touch with us and please let us know how we're doing. We love hearing from you. You can email info@fxmedicine.com.au or contact us via Facebook, Twitter and Instagram.